Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
Hello everyone, welcome back to another Research Works episode.
Welcome back, everyone, and welcome back to the microphone, Marissa. Nice to have you again.
Thanks for having me. Very excited for our chat today.
I thought you might be excited about this because we have a topic that is very dear to our hearts, actually, because we love a good research article about this, don't we?
And we love 6-minute walk tests, which will now lead me into describing what we're going to talk about today, which today we'll be talking about an article that was published recently in Developmental Medicine and Child Neurology just in June this year, titled 6-minute walk test reference values in ambulatory children with myelomeningocele. And the lead author, Dr. Karina Zapata, is here to join us for a chat today about this article.
Welcome, Karina.
Thank you. Thank you so much for having me.
It's so lovely to have this opportunity to speak with you. As you can tell, we're very excited about being able to speak with you about this topic. We haven't actually spoken about outcome measures, particularly relating to myelomeningocele. So we have so much to learn from you. I had so many questions. This feels like it's going to be a great masterclass.
Yes, very excited to get into your article with you. But before we do, I want to tell our listeners a bit more about you. So Dr. Karina Zapata is a pediatric physical therapist and researcher at Scottish Rite for Children in Dallas, Texas, where she blends clinical care with research on functional mobility in children with complex conditions like spina bifida, specialising in biomechanics and evidence-based rehabilitation. With over 25 peer-reviewed publications, Karina focuses on translating research into practical interventions, collaborating with multidisciplinary teams to enhance paediatric outcomes.
Love everything about that. Everything about that, Karina.
Very nicely said.
We're very excited to get into your article, but before we do, no podcast would be ready to begin without an icebreaker question. So our question today, being a podcast on walk tests, is what is the most memorable walk you've ever been on?
Good question. Karina, should we do guess first? Has anything come to mind?
Yes. I love going on walks, so I have so many memorable walks. But since this is a pediatric-focused podcast, I have to choose the time when I was a child, and it wasn't just one time, but I would love to go for walks with both my parents, and I would be in the middle and I would hold their hands. And my dad is German, and so we would say Engel, Engel, fliege, fliege, which is angel, angel, fly, fly. And whenever you say fliege, then my parents would have to lift me up with their arms, and I could basically be like I was flying. And so now I do the same thing with my kids when they're walking. They always want me to, lift them up
and
say the same phrase.
Beautiful. So. I love that. And I can actually visualize that. You describe that so beautifully, and what a lovely family tradition as well. That's so cool. Thanks for sharing that one. What about you, Marissa?
It's quite nostalgic. Well, as you say that, I was starting to think then about childhood walks. But, okay, now I'm going to do a childhood walk too. I remember we would walk the dog every morning, my mum and I, and we'd go for this 20-minute walk, but it was up this massive hill every day. And I remember to the point where it would almost scar me as a child, this massive hill. But it was, and I still go past it sometimes today. And in fact, it's making me think maybe I need to revisit that walk with my children to build a bit of strength and endurance. But yeah, I guess, with my mum, we used to do this walk quite regularly. And I look back now and I think that was quite intense to take a child on every day.
She was doing the right thing by you. She was increasing your heart rate. We're going to be talking about that today. But how beautiful is those are the things that you remember.
It's
those wonderful moments. And, you don't have to do anything vigorous. You can get out there.
Being outside. Beautiful. What about you, Dana?
So I am struggling to think of a walk that I did a lot in my childhood. I mean, I walked dogs a lot, but the one that comes to mind for this particular one is one that happened relatively recently, and I find it quite funny because I've lived in the same area for about 18 or maybe nearly 20 years now. And I've always gone for a walk down this beautiful path. There's like a nature reserve next to it. But I've never, for some reason, in all those years, ventured into the nature reserve until one day I saw a little path. This is about a year ago, so it's not that long ago. I ventured down this little path and then I realized behind all of this, concrete paving is this nature reserve that literally has wildflowers, like grassy wildflowers either side of the path. And there's a creek that runs through it. And there's ducks and ducklings. And I walked down there as an adult going, oh my goodness, I've stayed down this one path like everyone else does. And it just took a little bit of courage to kind of walk down this little beaten path into the bush to have the most beautiful wonderland. And I know it's very metaphoric, I think. But it was the most beautiful walk. And the whole time, glad no one was around me, I kept saying, this is amazing. This is beautiful. Why have I only just discovered this? So every year in spring, which it is now in Perth in Australia, I go down this path because I'm too scared to do it in summertime because there's snakes. So in springtime, I go down there and it's my favourite time of the season. It's my most memorable walk. So it was like a year ago that I discovered it.
And you still do it, which is great.
I still do it, yeah, except for in summertime because there's snakes.
That was what my story was going to be when I went for a walk and saw a snake, but we've digressed, so we won't revisit that memory.
Do you guys have snakes where you are, Karina?
Yes.
You do,
yes,
don't you?
rattlesnakes in particular.
Oh, wow. Yeah, that would be pretty scary.
Yeah, I Googled them not long ago because my kids wanted to know how they rattled. It's amazing. Yeah. Sorry, that's another conversation.
Those are good stories, yeah.
Yeah. So be careful on your walks, everyone. So, as you've guessed, we're talking about walking. Let me give you all a bit of a rundown about what we'll be talking about today before we have lots of questions for Karina. So this prospective cohort study established baseline reference values for the 6-minute walk test in 145 ambulatory children with a mean age of 11 years and 2 months with myelomeningocele, stratified by functional lesion levels and myelomeningocele functional classification, or MMFC. Conducted at a pediatric hospital from 2021 to 2024, the protocol followed modified American Thoracic Society guidelines measuring distances at 1, 2, and 6 minutes alongside physiological metrics like heart rate and perceived exertion. The results showed significant differences in the 6-minute walk distance by lesion level and by the MMFC, with distances 3.8 to 7.2 standard deviations below neurotypical norms. There were strong correlations between 6-minute walk distance and the 1 and 2-minute walk distance, with socioeconomic factors influencing outcomes with high Area Deprivation Index associated with shorter distances. There is a lot to draw out there, including my inability to use all of the acronyms. Apologies.
I think you did quite well. If you got me to do that, it could have been a lot worse.
There was a lot of syllables there, but shall we get into it?
Let's get into it. So, Karina, can you start by giving us a brief overview of spina bifida, particularly myelomeningocele, and why ambulation and physical fitness is so important in this population?
Sure. So I hope I remember this kind of like a 3-part question.
I can remind you,
first,
don't worry.
Yeah.
Spina bifida.
Yeah, let's go.
That is a condition where the spinal cord doesn't close or form completely during the first month of gestation. And since it primarily affects the brain and the spinal cord, it can affect how a child ambulates or walks and functions. But it also affects other body systems like the bowel, the bladder, the skin, and their cognitive and executive function. And typically, the higher the anatomic or functional lesion level at the spinal level, the more muscle weakness, the more orthopedic concerns there are, the more equipment and orthotic needs that a child has. And so the lower you go down on the spinal cord, like down to the sacral-level, there you have less muscle weakness and associated other comorbidities, and usually tend to have more bowel and bladder function. So things like self-catheterization and shunts may not be as big of a concern. There are also different types of spina bifida. And so myelomeningocele is the most common and the most severe type of spina bifida. We see all types of spina bifida in the spina bifida program that we have at our institution. And actually, we included originally the 193 kids with different types, but during the review process, it was suggested that we only include those with myelomeningocele because we expect their 6-minute walk test distances to be shorter or worse, which they were about by 100 meters.
Wow.
So then we kind of quickly talked about the other spina bifida types, but focused just on myelomeningocele for the purposes of this research study. And then we focused on the 6-minute walk test and using that kind of also as a surrogate. Actually, there's a paper that talks about how even though it's a measure of functional capacity, it also actually correlates with community ambulation. And so a lot of kids, as they get older, they grow taller, they get heavier, and especially those with lower function, they end up going from walking into a wheelchair. And as they get older, it's harder sometimes, a lot of times, to participate in physical activities. And so there's also this secondary deconditioning effect. And so physical fitness and walking is a really big concern for these kiddos. And we get asked all the time, how is my kid doing compared to last year? Because we see them at our institution on a yearly basis from birth to like adulthood. And to be able to give more specific, precise answers and also to be able to communicate amongst other health professionals better, we really wanted to look at this. And actually, we were inspired by the CP literature where they developed these longitudinal trajectories by GMFCS level, and they had these, distinct curves. And, we thought, well, the similar thing should be the case for kids with spina bifida by their functional lesion levels as well. And I think I'm jumping again here.
Oh, no,
I'm very passionate about this. But that's part of some of the reasons why we really wanted to study it.
And I suppose having that longitudinal trajectory is just so important because, like you said, these are the questions that clinicians will have. Like, is the child doing well? Do we need to target more intervention? And the families want to be able to know, and, everyone wants the best, right? So they are looking for these indicators. So up to this point, when it comes to functional capacity, what other ways do you as clinicians track progress in children with spina bifida?
Yeah, so because their functional lesion level is so important, we pay a lot of attention to their strength. And so just like a manual muscle test according to different, especially very key muscle groups. So for example, the thoracic lesion level, that's basically flaccid lower extremities. And then you have the high lumbar lesion levels. That's where they have the presence of hip flexors. And then mid-lumbar, that's the presence of knee extensors or the ability to straighten your knee. Low lumbar, that's the presence of ankle dorsiflexors or being able to lift your foot up. And then sacral-level is the presence of ankle plantar flexors or being able to point your foot down. And these functional levels are what's most commonly used. I don't know if Australia has something like in the US, the National Spina Bifida Registry. And so there's a lot of different institutions that participate and share and collect data. And that's kind of the agreed upon way that they classify these kids according to that regard. And so we make sure that we collect that for muscle strength. We also record their functional mobility scale, the FMS. So although it was validated in kids with CP, it's very also commonly used in spina bifida. And then we look at their sensation and we'll do some other, functional tests as well, depending on what the question or the concern is.
Sure. And I like those. They give you obviously an overall classification to help with communication, but it doesn't go into the granular detail about what a child is able to do, I suppose, when it comes to their ambulation, and that, you know, the variance that might occur across all of the different levels. So that's an interesting, you know, I can see the gap that you're trying to fill there when it comes to the literature as well as clinical practice. Really interesting.
Yeah, I find especially with children with spina bifida and they're around that age of maybe 2 to 5, and then, you know, they've established some walking with a mobility device, and you're at this point where you could remove some supports, but at the cost of that functional mobility skills. And then we've had conversations with families around using 6-minute walk tests, but then if we know more about the trajectory with these children, and particularly from a walking functional capacity by using the 6-minute walk test, that will also help us guide families in terms of how much we do, you know, look at, do we remove supports? Are we looking more at maintaining, and, you know, do we want to minimise other orthopedic issues in these children that we know have this substantial weakness depending on their levels? So I'm really excited for everything that's going to come from this, because already we use the 6-minute walk test, but to be able to give more behind that to these families is exciting.
Yeah. And Karina, just on that as well, a question about the myelomeningocele functional classification. Do you mind just walking us through that? Because that's something that I've not seen before. So please teach us.
Well, for full disclosure, that was not something that we initially were considering either.
Wow,
But during the review process as well, it was also suggested that we incorporate that. So that's why we have both the functional lesion levels, so like the mid-lumbar, low-lumbar, and sacral, and then as secondary outcome was also the MMFC 2 to 4, but really the MMFC or myelomeningocele functional classification ranges from 1 to 4, where 1 is the kiddos that have a lot of weakness, so they typically use a wheelchair. Just to take a step back, the MMFC, that's a newer functional classification system. It was just published a few years ago, and it considers muscle strength, the FMS, functional mobility scale, and what sort of equipment or assistive device the child uses during the day.
Right.
So there's a combination of those factors. So the first one, MMFC1, is where a child has pretty significant weakness. Their highest FMS would be a 221. So using a walker, short distances, but then a wheelchair for long distances. And then MMFC2 indicates that the child would have hip flexors, knee extensors, and knee flexors, that they would use a walker or assistive device for getting around, and their max FMS would be a 333. And then the MMFC3 indicates the presence of hip abductors. Their max FMS would be a 555. So they may not need an assistive device, but they could. And then an MMFC4 would be someone who has ankle plantar flexors, and their maximum FMS would be a 666. So kind of like your GMFCS ones.
Oh, wow.
Comparison.
I love that. Thank you. That was such a great description. I mean, it's confusing when you go, you know, you have some scales go up and other scales go down with the numbers. So I do need to think that through. But I love how there's a combination of factors put into that. And again, facilitating that conversation. Isn't it fun, the review process of getting an article published? Sometimes you get these great suggestions. You go, oh, okay, but then you have to go back and add in that data, don't you?
And we typically do record their FMS, and we do record what assistive devices they use and their muscle function. We just didn't describe it like context. MMFC, 1 to 4. So,
that's wonderful. It's wonderful. Yeah.
Definitely something we're going to use moving forward. So thanks for explaining that so well. Now, we're going to take a bit of a side detour on another important point of your article, which was around social determinants like insurance type and Area Deprivation Index, or the ADI, and they were highlighted as influence of health outcomes. From your experience, how do these factors interplay with physical function in children with myelomeningocele?
Yeah, so children with myelomeningocele you especially see the effects that someone with lower socioeconomic status or more, environmental or social factors impact their physical health. And especially, for example, here in Texas, it can get really hot during the summers. And so it's hard to just say, go outside and play, because even if you had sidewalks that didn't have cracks in them, so it would get in the way of your wheeled mobility, or if it was safe enough for you to play outside, or if you lived close enough to a park where you would have, something fun to do, you then still might be really far from a swimming pool. And then that swimming pool, is it accessible so that you have a safe way of getting in and out of the water. And then transportation can be an issue, making it anywhere, even to medical appointments. And so, or having someone who can be around to help you be active because your caregiver might be, working or whatnot. It's can be a big challenge. We're very fortunate to have a multidisciplinary clinic that works very closely together. So we have social workers that can sometimes look for programs that families may qualify. We have therapeutic recreationists, that specialists that can give adaptive cycling evaluations or help make phone calls to recreation centers to see what sort of programs they might have in the community for that child. But it definitely takes a team approach to try to help.
Yeah, so all the environmental factors that influence the ability to be able to engage in all the recommendations that we might have is an important determinant. So I suppose with all that information now, with a great background, do you mind just running through with us now the main aims of this particular study?
Yes. So our first aim was to develop these reference values for children with myelomeningocele between the ages of 6 to 18, according to functional lesion level. And the second was to look for associations between the 1 and 2 minute walk test with the 6-minute walk test. So basically to see if the distance walked after 1 and 2 minutes could predict how far the child was going to walk after 6 minutes. And then the third aim was to assess the impact of lower socioeconomic status on the 6-minute walk distance. And then we used insurance type and Area Deprivation Index as proxies for that. And in the U.S., the Area Deprivation Index, takes a lot of factors into consideration, like housing and employment, poverty, education. And just by typing in the address where the child lives, it gives you a percentile of how much deprivation they have in their neighborhood.
Right. And in terms of who was actually included within this study, I know that it was very focused on myelomeningocele, what was published here. But do you mind stepping us through what was the inclusion and the exclusion criteria of who was involved and the numbers of that in total?
Yeah. So total, there was 193 kids with all spina bifida types. And after we took out those that did not have myelomeningocele, we had 145. We only included those between ages 6 and 18, because we felt like by age 6, that's when they should be able to perform a 6-minute walk test most reliably and have achieved most of their function at that point. And then 18 is typically the age where they start transitioning elsewhere. So that's the most common age that we'll see. And then we were very fortunate also to have research coordinators that help with identifying and enrolling these patients, because they also participate in our spina bifida registry. And so by the time a child is 6, we have a pretty good idea of their functional lesion level and diagnosis. And if there's questions. We communicate with the developmental behavioral physician or the nurse who's seeing the patient and discuss together and make sure we're all on the same page.
That's wonderful. Yeah.
Now, I'm intrigued in terms of when you actually carried out the 6-minute walk test. I know you used the modified American Thoracic Society protocol, which includes monitoring heart rate, oxygen saturation, and perceived exertion. Can you explain why these additional measures were included and how they added value for understanding effort in this population?
Yes. So we used an oximeter on the kids' fingers to give us oxygenation and heart rate. And this was really actually eye-opening to us as we were doing the study because we saw how their heart rate jumped up like 50%. And they were like, you'd think of a 6-minute walk test as being just this kind of simple, almost easy type test. But for these kids, it was a workout. And sometimes you'd ask what their exertion was, and it'd give you a much lower number, maybe to try to mask how much discomfort they were having. And so you'd have this objective, heart rate which would show how high really went and how hard they were really working. And so also, you could say that if you do some intervention and their distance doesn't improve, but their heart rate doesn't go up as high, I feel like that's also a great piece of information to be able to have and to say, you're in better shape. Your heart doesn't have to work so hard to, expend this energy and get you from point A to point B.
So good, because you're absolutely right. Because the distance sometimes just written out, or graphed is just a distance, but it's how it was done that's what we're most interested in, right? Like you want to be able to work out, was this really difficult for you? And the way that we can do that through heart rate and looking at oxygenation levels. And it's phenomenal. We started doing that years ago here, and our kids are CP. And, when you do it, you're like, whoa, that's not what I expected. And, how much harder it is for them to work, or over time, how the 6-minute became a whole lot easier. I think those factors are so important, aren't they? I love that you did that.
Can I ask, when you carried it out, this is slightly off topic, well, on topic, but another added question. When you were doing this and the heart rates, did increase, did you ever have to stop the walk test because the heart rate increased to a certain level? And if so, did that ever correlate with when the child wanted a rest? Because I'm always interested about how the children, correspond themselves and how they feel their exertion when their heart rates are, jumping so high.
Yeah, we never, or at least that I could recall, stopped it because of what we saw. We would sometimes ask, are you feeling dizzy? Or, but the child would, in those situations, take a rest break when they were getting really, really tired. But it was really heartening to see that there were sometimes parents who were like, I don't know if my kid can do this. And they were the ones where they were just so proud of themselves to have even walked whatever that distance was. And so that was another aspect of the study. We weren't really expecting so many people to want to participate, but I don't think that these kids in general are asked to be part of things. And so they were very eager and willing to be part of this study. It was really nice.
I love that.
And the 6-minute walk test is so good for that because it's not too time heavy. The child, if you're asking them to walk at their own, rate over a 6-minute. And I think, like you said, sometimes you're giving them an idea, wow, we could walk 100 meters over, 6 minutes. Maybe we can take your walker to the park now. We don't have to be confined to indoor mobility and things. So there's a lot to come from the 6-minute walk test, if in case I am a big fan, in case you haven't noticed.
Can I ask before we head into the results, because now we can't wait to get into the results. It's just the 1 minute and 2 minute. Did you do them separately or did you do them with the 6-minute walk test? Like how did you time all of that, I suppose?
Yeah, so we did it at the same time. So we had bean bags that we would throw after 1 minute to mark that distance, and then after 2 minutes to mark that distance, and then get both to so that it could just be all done at the same time point.
Sure.
Perfect.
And the child just had to do one test. Like their involvement in this was just to do it once. Okay, fabulous.
All right, results.
Here we go.
I'll just do a general question to make it easier, and then you tell us what you would like. But Karina, what were the main results from this study?
Okay. So for our first aim, we did see distinct distances walked by functional lesion level. So those with mid-lumbar levels, they walked shorter distances than those with low lumbar levels who walked shorter distances than those with sacral levels. And it was I want to say it was about 75-meter difference between each lesion level. And the minimum detectable change has been found in spina bifida to be about 36 meters. And so it was definitely clinically meaningful.
Yep.
And it's similar with the MMFC 2 to 4, also very distinct kind of distances walked.
Yep.
The second finding was that there was a very strong correlation with the 1 and 2 minute meters walked compared to the 6 minute walk test as far as meters walked. So it was like 0.93 and 0.96, which is very amazing
phenomenal.
and remarkable. We weren't expecting that.
Yep.
And then our third finding was that lower socioeconomic status did impact how far they walked. So they walked, kids with public health insurance and higher deprivation scores walked fewer meters.
That is such an interesting compilation of results, isn't it? Was there, I don't want to delve into all of it, but was there anything that was surprising to you that came out of that?
Well, I think I was surprised by how strong the correlation was with the 1 to 6 minute and 2 minute to 6 minute meters walked, because I felt like some of these kids, they start off really strong and then they might slow down because but it was really, I think it helped that we had 145 kids.
Yeah.
So there's that, helps with outliers, but it gave me a lot more confidence in saying that, if for whatever reason you're not able to do a 6 minute walk test, then a 1 or a 2 minute is also really helpful. And we gave, the expected meters and standard deviations there. So clinicians could then also have an idea of how their specific patient is doing compared to someone else with that specific diagnosis.
Yeah, that's fantastic. You're absolutely right. The 1 minute and 2 minute, I have to admit, I'm always a little bit reluctant to use them sometimes, because you're like, does it really reflect what they might do in a community pace? But the fact that they're so strongly correlated means that if you are really, what you often hear is we're really tight for time, don't have time to do these measures. But 1 minute is something that you can do, right? You can walk for 1 minute and have a good idea about where they are currently functioning and where they might be headed and how to plan your intervention. Like, I think it's so valuable.
A lot can come from that. Exactly. It's quick, it's feasible. You can do it relatively frequently to track.
That's fantastic. Yeah. Did you find any differences with regards to age? I mean, you had quite a lovely age range, didn't you? From 6 to 18, covering that school age. Did you see any trends there?
Yeah, so we did notice that up until the age of 12, there was kind of the one distance, and then after age 12 to 18, there was other distances, like for a little bit further distances walked, but it wasn't as strong as we were expecting. And I don't know if that's also because sometimes, especially with the lower function, that it gets harder to walk the older you get. And so I just feel like what we're collecting now is the longitudinal data to where we have the same kids who we're tracking on a yearly basis to seeing individually and with them, how are they doing over time.
Yeah. That's super interesting, isn't it? Because that, again, would be really valuable.
Yeah, to see whether there's that functional decline and when it happens and what we can do then to prevent that is obviously a huge thing.
Yeah, absolutely.
So from your results, how do they compare in this group compared to neurotypical norms?
Yes. So the kids with mid-lumbar levels, they were about 7 standard deviations below the neurotypical youth. And those with low lumbar were about 5 standard deviations below neurotypical youth. And those with sacral level, so those, the least affected, they were still about, on average, 4 standard deviations below the neurotypical youth, which is why, again, we're very, shows the need to have their own kind of norms so that we can better understand really how they're functioning compared to someone with their similar function. And also this has kind of helped us explain to parents how their child is functioning and, helping them understand that not all spina bifida is the same and how really what we're trying to achieve and how even let's say if we try an orthotic device or something else, we can give better information as to how that might change things as well.
Yeah, that's fantastic.
It is so useful to be able to have those norms within their diagnosis group because, like you said, so much more can come from that in terms of guidance and reassurance to the parents.
It's true.
Because you can't compare.
Always say, you can't compare. Yeah. My child's so individual. And yes, the different levels do dictate so much about function, but this is given a lot of clarity. Yeah.
Now I'm going to delve back in. So in terms of I would love to know more about the relationship with public insurance or Area Deprivation Index.
What are your thoughts on that?
Yes.
I mean,
I know it's like a very big picture kind of a question. So in general, if you have public insurance, you typically have a lower socioeconomic status. So you would usually have higher deprivation index. And there's still a lot that we really don't know how all the factors interplay, but the fact that it did show that it is affecting their function really kind of helps us see the importance of addressing this and trying to take it upon ourselves to be thinking about the bigger picture and really ways that we can be supporting families on a broader scale and not just, are they going to come to therapy or not?
Yeah, that's right. I find this particular finding just gives so much insight because it shows what's modifiable, in terms of what function can look like. There's the environmental and contextual opportunities that can be provided. And you think about finite resources, where would you spend them? Would you do more sporting groups or race running opportunities, and where are your physical activity options and where you might target them because it's modifiable. Like there is something that you could possibly do about it if you can hone in your resources in the right way, right? But it shows you that providing intervention, being really focused on improving physical activity does work and it can work. I mean, that's how I see it. I don't know, is that how... What do you think about that, Karina, in terms of a perspective?
Yeah. And so, I mean, we have like summer camps where we try to really encourage, it's a camp dedicated for kids with spina bifida where they can be together, and it's basically an intensive, week-long experience. And there's so much that can be covered and targeted. And then there's different like learn to golf and adapted, sports programs that they can participate in. But I feel like the week-long summer camp is the easiest and best way for if you're, a family with limited time and resources and whatnot to say, okay, I can do this. So
it also gives the child that autonomy to be like, these are my, they can meet peers with a similar diagnosis.
That's right.
And I think from a young age to have that yearly connection is quite an amazing thing. Also, I guess whether whether there's workshops and things like that is teaching them about, things they could do to improve their fitness and stay physically active. And again, you're empowering the child, which I think is amazing.
Yeah, that's right.
But also even that you have a social worker in your multidisciplinary team as I think such a good
shows the value
of not only, yes, obviously we know, like Dana was saying, the intervention makes a difference and being on your feet is so important. But how can we get this to the people that are
that's right.
not able to achieve the same results?
The behaviour change, you're really thinking about all those aspects of bringing in the different skills and the different areas now, because it's a multidisciplinary approach. I guess, Karina, we've covered all of the main aims and what that means. From your perspective, as someone who's so passionate about this area and works with these kids, these youth and their families so much, what do you believe is the main implication, like speaking out to other therapists who are out there right now working with children with spina bifida? Based on your results, what would you really want them to be adopting and using from the research you've just done?
Yeah, so there's several.
Good, go.
So as far as I love the structure, since unfortunately there's such little research in spina bifida. There's a lot more in CP, where they talk about, for example, collaborative goal setting. So really being able to talk to the family and the patient and to say, is first off, can you do this 6-minute walk or 1 or 2-minute walk so that you can see how they're functioning compared to another child similar to them, or ideally even over time, so that way you can have discussions about, is there an intervention that might be helpful? Would that look like an orthotic device? Would it look like a change in your assistive device? If you're getting older and your school campus is getting bigger and it's harder for you to get around, especially, those sorts of conversations. And then therapy. So would you be interested in doing an intensive therapy bout? There's a study that was published from the Netherlands. At this point, it was almost 15 years ago, where they did intensive treadmill training in kids with spina bifida, and their 6-minute walk tests did improve after twice a week, 12 weeks. It was a home-based treadmill training program. So the therapists were going to the kids' home. And also just, asking and figuring out what we can be doing, what's a priority for the family and the child. Beautiful. Since there is a lot of deconditioning that can be accompanied by the diagnosis, even if you might not be changing their muscle architecture, for example. And so I also feel like in the CP literature, these kiddos are starting to be treated more like athletes, where you're really challenging them and seeing what they can really do. And I'd love to, have more of the same with our patient population, where it's not just walk in the park, or like we were just talking about sorts of things, but they're really, their heart rate is going up. They're really, being challenged and trying to see if we can really move the needle.
I love that. And as you're talking about that, I just go, there is so much, there's diagnostic specific information that's so important for clinicians to know, right? We need to be able to understand that. But when it comes to an intervention, everything you've spoken about there, very inspired from the area of cerebral palsy being, such a big area of research. But it's the same kind of thing, right? It's the goal setting. It's being collaborative. It's thinking about those motor learning strategies that are sort of, really promoting that autonomy, but also your physical activity strategies. So, there's an element there that's quite, I guess, transdiagnostic to be, as to put a term to it. But I think that says to a therapist that's working with kids with maybe a big, caseload, is that you can be doing these things across these different diagnoses and that you can be really effective with them, right? We're seeing the same kind of thing. But it'd be good to have very specific information about children with spina bifida in particular, so we know what the aim could be and what the trajectory might be. But I think that gives a lot of hope.
It's very exciting. And we know, we know the importance of exercise. We know in the population of cerebral palsy. So
that's right.
Like you said, for this population of children and adolescents with spina bifida, if we can give more information out there, more supportive data to be like, do you know what? No, you don't have to, whether it's, like you said, adaptive cycling, different ways to be active and on their feet to influence their endurance and exercise tolerance.
That's fantastic.
Love it. Okay, so here comes the question, where to from here, which I'm excited about, hearing that there's more longitudinal data. But yeah, where to from here for you and your team?
Yeah. We're working on the longitudinal part. We're also doing 6-minute push tests for our wheelchair users and trying to get, some reference values for those kiddos. And so there's also actually some patients, they do both the 6-minute walk test and the 6-minute push test if they're kind of on the border. And that way, there's not very many, but, there is that whole transition where you're not really sure what's their primary, mode of getting around. We were trying to do some intensive treadmill training, outpatient therapy at our institution, but it is not home-based. It's at a hospital. And we did notice it was very hard for families to make it twice a week for at least 8 weeks to these sessions. And so I would love if anyone else could, who goes to families' homes. You'd have to have a portable treadmill, which I don't know how many people have, but to make it, make it more feasible, something like that would be wonderful. Also involving dietitians in the whole fitness and health conversation, since maintaining a healthy weight as these kids get older is always also really important. And that's also, I feel like, would take a lot of time and energy as well.
Yeah, no, that's fantastic though. That's so wonderful. Well, we can't wait to catch up with you again to be able to talk more about, as things progress, and love to hear about the longitudinal data, of course. But before we talk about next time's date, Karina, let's head to our final segment, which is called Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he has been listening on this conversation. He hasn't heard any of this content before, so I'd be interested to see what he's thinking. Before he has a chance to ask you a question though, Karina, do you mind just summarising this area that we just spoke about in about a minute or so? And Ed, you'll have time for one question. So take it away, Karina.
Sure. So, we did a study on 145 children between the ages of 6 and 18 who have myelomeningocele, which is the most common type of spina bifida. And we developed reference values for how far they could walk after 6 minutes, and found distinct distances walked depending on their anatomic functional lesion. So those who had more muscles present walked further than those with less. And we also found that the distance walked after 1 minute and 2 minutes predicted how far the child would walk after 6 minutes. And our third main finding was that socioeconomic status impacted how far the kids walked after 6 minutes.
That is phenomenal. It's a lot of work to put into 60 seconds, isn't it, Karina? You did a fantastic job. Well done. All right, Ed, are you ready?
We'll find out.
Okay, off you go.
So it's been a fascinating conversation, and I'm a maths computer kind of guy, so I kind of appreciate the fact that there was ways that the 1 and 2 minute walk test, am I getting that right?
Yeah.
Correlates with the 6 minute one. And so my head always kind of goes to how you can democratize these things, and obviously the 1 and 2 minutes kind of makes it a little bit easier in a clinical setting. I'm assuming professionals are very not time poor, but they don't have a huge amount of time in clinical sessions. So rather than, and I don't know if I'm getting this right, but rather than perhaps doing the 1 and 2 minutes in a clinic, can this data be collected at home? So I'm just wondering whether that further democratizes this, and mobile phones and sensors can kind of tell when people are walking on a flat surface versus an incline or a decline, and
up the hill with your mum.
And whether that kind of would help with, I'm not going to get this right, longitudinal studies.
Oh, very good.
So data that's kind of collected that's not necessarily in the domain of the clinic, and it kind of keeps feeding into something that might be more like a learning healthcare system that kind of develops this kind of thing.
Such a numbers person.
Yeah.
Karina, what
Sorry,
do you
I'm just
think
throwing
about
out
that?
buzzwords at this point.
No, and we've been actually trying to also improve our communication with school therapists and kind of use the 6-minute walk as a way that, they can use that as well for tracking how a child is doing. And then we get these assessments from other community therapists for us to also kind of better understand how the child is functioning. But I agree, anyone could be really doing a 6-minute walk test. And the families can have the knowledge, right, to know how their child is doing or may not be doing as far as changing. So yes, I love that. And I think it's also a way for, if you have a competitive child and they want to see if they can beat their time.
Yeah, that's right. Yeah, I love that idea.
Have that.
That's a great idea, Ed. Maybe
research topic for someone.
Yeah, that's right. An honours student or something that wants to come in and do it. That would be a great idea. Love that. Well, Karina, I feel like I've learned so much from you today. That was just absolutely fantastic. Obviously, Marissa and I are kind of fangirling over, the use of a 6-minute walk test and what that means. And I think it's because it's so significant, right? It impacts a lot of planning, and we want to support families. So thank you so much for doing this work, to you and your team, and for sharing it with us today.
Oh, thank you so much for having this conversation with me.
We loved it.
Excited to chat again sometime.
Yeah, that's right. Well, to all of our listeners, please head over to our website, researchworks.net. We'll definitely put a link of this paper there for you to have a read. There's so much more in there. If you want to look at the stats as well, Ed, go and have a look at the tables and the stats. There's so much in there. Please go and have a look. And also head to researchworks.academy, where we have a whole free online platform for you to look at tools of the evidence. And one of them is the Outcome Measures Hub, which has a lot of outcome measures there for different populations. And I'm pretty sure we've included links to this particular paper on there as well, just reference values. So have a look there for information that relates to your child and who you're seeing. It's a free resource. Please go ahead and use it. But for now, we're going to have to say thank you and goodbye. Thank you. Once again, Karina, thanks for staying up late for us today in Texas.
Yes, thank you so much.
Yeah, thank you.
No problem.
And to all of our listeners, we'll talk to you all again next time. Bye, everyone.
Bye.
Bye.